Now I will be demonstrating about posterior superior alveolar nerve block. The indication for posterior superior alveolar nerve block is any procedure to be done on the molars, and when we are extracting the first molar, the mesiobuccal root is supplied by the middle superior alveolar nerve. So except for the mesiobuccal root, the posterior superior alveolar nerve supplies all the molars. The anatomical landmarks for the posterior superior alveolar nerve block are the mucobuccal fold, zygomatic process of the maxilla. Just posterior to the zygomatic process is the infratemporal surface of the maxilla, the maxillary tuberosity, and the anterior border of the ramus of mandible. So the technique for the posterior superior alveolar nerve block for right side is different and the left side is different. So I will be demonstrating first on the right side of the patient. The mucobuccal fold is palpated in the premolar area, and then we go posteriorly to locate the zygomatic process of the maxilla. Once we locate the zygomatic process of the maxilla, just posterior to that is the infratemporal surface where we find the concavity. So once we locate the concavity, we have to rotate our finger in 180 degrees so that the bulbous portion which was in contact with the maxilla is rotated towards the lip and the fingernail is rotated towards the maxilla. Once we rotate the finger is then lowered and it is at 45 degrees angulation to the mid sagittal plane. थोड़ा बंद कीजिए. The needle is then inserted parallel to the palpating finger at 45 degrees to the mid sagittal plane in an upward, inward and backward direction. Remember here that we don't get any bony stop and we need to stop the insertion of the needle to approximately half of the length of the needle, approximately 17 to 18 millimeters in length. Once the needle insertion is approximately half of the length or 17 to 18 millimeters, that is where we need to stop and aspirate in two planes and then slowly inject 1 to 1.5 ml of the local anesthetic solution. Care is taken that we need to be as close as possible to the maxilla because we have pterygoid plexus of veins which can lead to the most common complication of hematoma if we puncture the pterygoid plexus. Side technique, the operator's hand goes around the patient's head and the same landmarks are palpated, that is the mucobuccal fold, and we reach the zygomatic process and then the infratemporal surface where we find the concavity. One thing to be remembered here is we don't have to rotate our finger because already the finger is in a rotated position. Again the needle is inserted following the direction of the palpating finger in an 45 degrees to the mid sagittal plane in an upward, inward and backward direction, and the solution is deposited after aspirating 2 times. Coming on to the subjective symptoms for the posterior superior alveolar nerve block, there are no subjective symptoms. The objective symptoms have to be checked with a sharp instrument such as a straight probe in the area of interest. Make sure that the sharp probe enters the gingiva and hits the bone, and look at the reaction of the patient. If the pain is there, patient's reaction will be seen in the eyes.